Hi, I'm Dr. Tro Kalayjian, and I'm so happy to be here with you today. I'm going to be discussing hyperlipidemia. We're going to be examining the ACC/AHA guidelines in relation to carbohydrate restricted approaches, and thank you for joining with me. So, I'm Dr. Tro. As I said, I'm an ABIM and ABOM certified physician, both in internal medicine and obesity medicine. Okay, so my financial and personal disclosures. Well, personally, I failed basically low-fat diets, Weight Watchers, calorie counting, and I've had personal success with low-carb approaches. So that's a bias you should know. I work as a medical director in a practice that's supportive of carbohydrate-restricted modalities. And I'm a co-host of a podcast called the Low Carb MD Podcast. Again, we have zero commercial interests. We're completely funded with donations. It is not for profit. And I should say I have a family disclosure to make. My wife makes low carb, almond flour, no sugar based mixes. So this is a relevant disclosure. The objectives today are to review the ACC/AHA atherosclerotic cardiovascular disease primary prevention guidelines and as they relate to hyperlipidemia and its guidelines. And how does that all relate to therapeutic carbohydrate restriction? I think this is the key point of the lecture. And we're going to outline the need for flexibility in these guidelines using both clinical data and survey data. I'm going to talk about a newly published paper from myself, the brilliant Nick Norwitz, Dave Feldman, and Dr. Adrian Sotomayor, and Dr. David Ludwig. So that'll be a study we'll talk about towards the end. And we're going to discuss nutritional strategies for hyperlipidemia as well as pharmacologic approaches. So this will be a very clinical lecture. All right, we're going to start with a couple of cases, right? Case one is a 56-year-old man with a past medical history of hyperlipidemia, PVCs, his degenerative disc disease in his spine. He has a family history notable for some hypertension in his dad, some diabetes, and he takes an occasional sildenafil. His BMI is 22. His body fat percentage is very low at 12%. And he comes to your office and he says, now look, I have some cholesterol issues and I need your help. And he explains that his values are consistent with that of using less medications if possible. And he wants help addressing his problem through diet. So what are the things that you may want to know? Well, what are his lipids? So the lipids that he presented with was, to my clinic, was a cholesterol of 797, a LDL of 665, and an HDL of 122, and triglycerides of 50. Right, so we want to start thinking, how do we approach this? What's going on? What do we have to pay attention to? What are the concerns here? So maybe you'd want to know what's his current NMR, right? And is very low small particle count, large LDL size, no C-reactive protein, normal fasting insulin, leptin, TSH, and testosterone. And his LPIR score, his insulin resistance score, was less than 25. It was optimal. Maybe you'd want to know some more. What about his prior lipid data, prior to his new diet that he presents with these abnormalities from? Well, prior to his low-carb diet, his carb-restricted diet, his cholesterol was 214, his LDL was 116, and his HDL was very high at 81, and triglycerides quite low at 84. Pay attention, right? He didn't have an FH picture before he did this diet. He didn't have labs consistent with familial hypercholesterolemia, which is, in the current guidelines, an LDL over 190. What about his family history? Okay, there was no early cardiac deaths, no strokes, no cardiac events that happened at an early age. What about genetic testing? No, well, we did a 7-gene panel. We found that those were negative. Why is that important? We'll talk about it. Imaging, well, we got a coronary artery calcium scan, and his was low, but not zero at 24. And we did a carotid intima media thickness, and we found that one side was 0.07 and the other was 0.09, and let's say on average 0.08. And which is, again, not optimal. We'd like it to be a little bit lower. And physical exam, okay? And other pertinent information, this patient clearly said his values and preferences to me, that he would like, not to use pharmacotherapy if possible. And he had no xanthoma palpable on physical exam, and I'll talk about what that is. I did an ultrasound of his Achilles, and there was no thickening, which is seen in familial hypercholesterolemia. And there was a questionable eye finding. He said, is this the xanthelasma, which is a cholesterol deposit in the eye? And I'll show you what that looks like later on. And honestly, I think it was probably not, but it could have been, and I treated it as if it was. So let's go to the next case. Well, actually, before we do that, how would you approach that patient? What would you do, right? What are your thoughts? How do you address his problems, his concerns, right? I think that's important to understand, that these patients will come to you and you're going to have to figure out what's the best next step forward. Here in case 2, we have a 49-year-old female with a past medical history of high lipids, osteoporosis, amenorrhea. She has a history of anorexia nervosa in remission, some cardiomegaly on a chest x-ray, but a normal echo, history of resolved vitamin deficiencies, some family history of hypothyroidism and diabetes and hypertension. Medications basically include some supplements, and her BMI was 21, total body fat was 22.5%, again, on the leaner side. And she presents to your office. She presented to my office with hyperlipidemia and requests help with a non-pharmacologic approach to lipid management. Patient knows her lipids are due to her diet, and despite several cardiologists' advice to the contrary, she would like help finding an approach without medications. Her lipids reveal a cholesterol of 658, an LDL of 551, an HDL of 110, and triglycerides of 58. What is going on here? What more information would you want to know? Right? So her current NMR, no real small particle count, large LDL size, low C-reactive protein, normal kind of thyroid hormone, LPIR score, fine. Well, what about her prior lipid data prior to doing a carbohydrate restricted approach? What was it? And you can see her LDL was 122, her total cholesterol was 209. Again, not consistent with FH. And her family history really had no cardiac deaths or strokes or cardiac events. Well, what about her genetic testing? That's something you'd want to know. It was a 7-gene panel was negative. And her imaging, she had a CAC with 0 and a CIMT that was really healthy, quite healthy, right? And what about physical exam and other relevant information? She had no xanthomas, no xanthelasma, and she was very clear. Look, Tro, I want to do this without medications. How do you approach this patient? Case 3, we'll run through 3 more cases, so bear with me. 44-year-old male has some hyperactive nodules, some cholesterol, history of somebody who had an MI, but not at an early age, diabetes, hypertension. There's some clots in the family, multiple myeloma. These medications include magnesium, omega-3 fish oil, vitamin C, multivitamin. Right? 2 years prior, his BMI was 30, and his total BAT was 24%, and he presents to you much leaner now, and his cholesterol, after going on a low-carb diet, and his cholesterol is 311. His LDL is 239. His HDL is 65 and triglycerides 50. What would you want to know? What should you be thinking about? Again, let's see. Let's check his NMR. His NMR profile, again, looks optimal. No C-reactive protein, normal insulin, thyroid, leptin. His prior lipid data, not consistent with FH. This is important, right? We got his old records. Total cholesterol of 197, LDL of 137, HDL of 45, triglycerides of 62. No family history of early cardiac events or deaths or stroke. Genetic testing for FH was negative. His calcium score was 4, and his CIMT was 0.05. So it's a low score, but high for his age, and otherwise no inflammation, right? And what do we find on physical exam and relevant patient information? Because there's no, cholesterol deposits in his eyes, tendons, anywhere else. No xanthomas, no xanthelasmas, right? And he basically said that, look, he'll do a medication if he needs it, but he'd like to try something else. Case 4, 56-year-old male has a history of AFib, testicular cancer in remission, GERD, autoimmune thyroiditis, and hyperlipidemia. He has some coronary artery disease in the family, but no early cardiac deaths. Some prostate and thyroid cancer in his family. He's on aspirin, omega-3, CoQ10, and some pantoprazole and verapamil. And his BMI is 27, total body fat of 21, and he presents to you for guidance on lipids. He's lost weight with a low-carb diet. He has tried a statin before, and he's experienced some cognitive issues, and he's re-challenged. And he doesn't want to necessarily use it if he doesn't have to. So is there another option? Is there another pharmacologic drug he can use? Is there something he can do with diet? He's willing to try. His total cholesterol here is 387, LDL of 317, HDL of 59, and triglycerides of 54. What would you want to know? His current NMR, pretty excellent. No high CRP, no thyroid issues, no insulin issues, and LPI are optimal. His prior lipid data was basically normal, right? Within the normal range. His LDL was 141, not consistent with FH. Are you seeing a pattern here yet? No early cardiac events, no deaths, no stroke. Genetic testing was negative, right? And his imaging, he had a calcium score of 1, CIMT of 0.5 bilaterally. So fairly low risk, very low risk for his age. No, nothing pertinent on physical exam. And of note, the patient has not tolerated the statin. So one thing to note while I'm here, I'm just going to let you know, there was an interesting study of statin re-challenges. So there was an interesting study that was published within the past year that took patients who reported adverse events from statins and randomized them to placebo or statin therapy and saw what the adverse events rate was. And there was a 10% difference in adverse event rates on the statin re-challenge, meaning most people who report some adverse events from statins when re-challenged may not report those statins. It may be due to a nocebo effect. That's something to note. Case 5, 58-year-old male with a history of pulmonary embolism and hyperlipidemia, family history of COPD and other things. Oh, I gave away, but his genetic testing was negative, and he's on apixaban. He lost weight on a low-carb diet, and he says he left his last doctor because they were forcing a statin on him, despite losing that much weight. So his lipid data, his total cholesterol was 423, LDL was 336, HDL was high at 69, triglycerides low, 74. What would you want to know, right? NMR looks great. Other labs look great. No other obvious findings. Prior lipid data looks good. Prior to doing a low-carb diet, he had no real major issues, mild hyperlipidemia, okay? No real early cardiac deaths, right? No strokes in his family. Genetic testing, as I said, was negative. Imaging, right? He had a calcium score of 33.2. His CIMT was 0.6 bilaterally. Now, it's not exactly ideal, but it's not exactly high risk either, right? Based on imaging, right? Based on imaging. So is this FH? You know, he had no xanthomas, no xanthelasmas, and he basically said that he wanted to be treated respectfully. He wants a full dialogue of risks and benefits, right? Let's figure out what to do. And one last case, okay? We have a 41-year-old patient with a past medical history of hyperlipidemia, gallstones, and he had a cholecystectomy. He has a family history of cardiac disease, okay, in several people, including his father, who had a stent at a young age. He had a mother who had a stent at a young age. He's had a fatal heart attack in his grandfather at age 40. He had a fatal heart attack in his grandmother at age 50. A paternal uncle had a fatal heart attack at age 50. Triple bypass in his uncle at age 37. Multiple bypasses in another uncle. Another uncle who had a bypass at age 30. Another uncle who had over 27 angioplasties and eventually a stroke. He presents with an LDL-P of 196, small LDL of 690, an LDL-C of 191, HDL of 47, total cholesterol 260. And other labs look okay. Of note, his lipoprotein A is also elevated, 255. You review the CAT scan from his hospitalization for his cholecystectomy, and you find that back then, about a year prior, there's calcifications on his aorta. What do you do? How should you approach this patient? I want you to start thinking about these cases. So one of these cases is not like the others. Can you pick it out? Which one is it? Right? We're going to talk about it. So what is a good approach to these patients? Should everybody be treated the same? Should nobody worry about their LDL? I don't think that's the right answer. Let's figure out who needs to worry and maybe who doesn't. And does LDL matter or does it not matter? Well, let's start with the guidelines. What do the guidelines say? How did we end up at a guidelines? I think it's important, to understand how the guidelines have evolved over time, right? Out with the old and in with the new, right? The ATP1, they recommended bile acid resins, right? They recommended fibrates to lower cholesterol, right? And they treated people who had a high cholesterol based on the number. And that was true at the updated guidelines in 1994 and 2001. And even up to 2004, even really honestly, up until about 3, maybe 5 years ago, right? It became about risk. But up until, very recently, the management of primary prevention was lipid number based. And the guidelines have since kind of shifted away from it. They've shifted away from it. So this was the old way, just lower the cholesterol, right? And what was that rooted in, right? We'll talk about it. So the new guidelines, the new ACC/AHA guidelines, they're a little bit different. Right? They're based on risk. So you'll see here, if you follow the algorithm, well, first, does a patient have an LDL over 190? All of those patients did, right? At least on presentation. So per the guidelines right now, every single one of them needs a statin. Every single one of them has FH according to the guidelines. But is that true? I'll tell you that I'm convinced only one of those patients had FH. In any case, if they're at high risk, if they're, if you're worried about FH, if they have a persistently elevated LDL over 190, and they have classic family history, physical exam findings, right? You certainly want to get them a medication that will reduce their risk. If the risk is high, you want to reduce the risk, or at least offer potential treatments. Be more aggressive in how you monitor. If they have diabetes, the same thing. The risk of disease goes high. And so medications, right, matter more the higher the risk. So currently the guidelines say if you have this high LDL, if you have diabetes, you want to take a statin, right? You want to take a statin. And if you're over the age of 75, you discuss it. You discuss it with the patient and come up with a clinical and mutual shared decision-making, right? And then for everybody else, if you're 0 to 19, it's based on if there's familial hypercholesterolemia, right? If you're between the age of 20 and 39, some risk factors for sure, you'll see here, but it's mainly based on risk, right? Certainly if you have FH, they want you to consider it, right? And if for most people coming to your offices, age between 40 and 75, if their LDL is between 70 and 190, you basically want to determine their risk. And how do you determine their risk? I like to use 2 different scores. The AHA ACC risk score. It's a risk calculator. You can go and just go through it and ask your age, your smoking history, family history, cholesterol levels, hypertension, diabetes status, etc. And it gives you a risk assessment. There's another score that's really excellent, which is called the MESA 10-year risk calculator, which is based off of those similar findings and your CAC. But what the guidelines want you to do is determine if your risk is low. So if you have an isolated high cholesterol at 189, right, and your risk is low, you may consider not giving a statin. You may just monitor and emphasize lifestyle. That's the recommendation right now. If the low risk, right, and LDL between 70 and 190, right, you want to discuss lifestyle modifications. When you get above that, right, you want to consider some risk enhancers, right? Is there a history of family heart, premature death? Is there a persistently high LDL? Not in any of those cases, except one of them was there, persistently high LDL. Is there any chronic kidney disease, metabolic syndrome? No, most of these patients had reversed their findings. Are there cultural considerations that you need to make? They had an inflammatory condition. right? These are things, what's their CRP, their LPA level, their ApoB? Do they have any signs of peripheral plaque deposition that you need to consider from an elevated ABI, ankle-brachial index, right? These are things you want to consider. And if their risk goes up, you want to consider potentially a calcium score, right? And a calcium score is a beautiful test. Helps you judge who's more likely to benefit from medication. If that calcium score is high, typically above 100, risk goes up. It's much more above 400, right? And if the calcium score is 0, risks are typically very low, right? Not 0, but low. So it's a risk-based assessment. What is your personal risk? Will you benefit from a medication? Low risk? Not likely. None of these special considerations? Not likely. So how do we get from cholesterol levels to assessing risk? Let's talk about the famed cholesterol hypothesis. Okay? Because of epidemiology and clinical trial data, the wide-standing belief is that cholesterol is linearly associated with atherosclerotic risk, okay, due to population-based data and then medication-based data. I'll talk about why. The current approach to lipids is based on the epidemiologic data, medication, clinical trial data, and genetic and Mendelian randomization data. So I'm basically going to talk about how we got here and look at the epidemiologic data, right? If you look at cholesterol as it relates to cardiovascular disease, right? The higher the cholesterol, the higher cardiovascular disease go and cardiovascular disease mortality, right? Stroke does not have as strong of a relationship, right? Well, why is there a U-shaped curve here, right? Why is there a U-shaped curve? If the LDL goes down in the Mr. Fit study and it's below 160, why are people dying? Well, what makes cholesterol low? Typically cancer, typically poor nutrition, typically inflammatory autoimmune conditions that can drive LDL down, chronic infections, right? Those people don't do well. But if you look, there's a apparent linear relationship between cholesterol and cardiovascular mortality, right? But if you look at all-cause mortality, right? All-cause mortality, it's not the same. When you look at most population-based data, there's a U-shaped curve. There's somebody who's doing well if the LDL is high. There's somebody doing poorly if the LDL is low, like those conditions I mentioned: end-stage renal disease, advanced age, poor nutritional status, dementia, right? These conditions, lower LDL is associated with worse outcomes. Well, who does worse if the LDL goes up? It's cardiovascular disease, heart attack, stroke, right? These are the ones that tend to go up as the cholesterol goes up. Now, are there other factors? Absolutely. Diabetes is probably 5 to 10 times more of an issue than cholesterol is. Metabolic syndrome is probably 3 to 5 times more important than cholesterol is. So yes, there are other factors that are interrelated here, but these are the findings from the epidemiologic data. And because of this data where the cholesterol goes up and the cardiovascular mortality goes up, this has led people to think that they're linearly related. Well, there's more to it than that. If you look at the medication trial data, right, and you take all the different drugs, whether it's an ileal bypass, a new PCSK9 inhibitor, a statin or diet modifications, niacin, ezetimibe, and you line up their LDL reduction and you look at what it does to vascular events, not all cause mortality, but vascular events, drugs that lower lipids seem to linearly lower cardiovascular mortality, but not necessarily all cause, right? And that relationship is linear, right, or nearly linear. And if you look at the different medications, right, I want you to pay attention to this graph. There's a lot of medications that lower cholesterol or impact cholesterol. Not all of them have shown to affect cardiovascular mortality. Not all of them have been shown to reduce all-cause mortality. The only medication that could arguably be said to decrease all-cause mortality is statins. And we'll talk about the WASTOPS data in a little bit, right? Bile acid sequestrants have been shown to decrease cardiovascular mortality, but the data is limited. Niacin also, pretty limited. Fibrates, very limited effect. They help the number, not so much the effect on all-cause or cardiovascular mortality. Ezetimibe seems to decrease cardiovascular mortality, but no effect on all-cause. Interestingly, it's important to note how these medications affect CAC. Statins increase CAC. PCSK9 inhibitors decrease them, right? Vascepa, which is basically purified EPA, right? It's basically, omega-3 on steroids, right? It decreases, it prevents prevents the progression of calcifications. And it also decreases cardiovascular mortality and trended towards reducing all-cause mortality, right? So these are the effects we have. And these are the reasons why doctors use them, right? They're trying to help perceived risk, right? None of these are without complications. Statins tend to raise liver enzymes. They can cause rhabdo, right? They have other issues that we need to be cognizant of, right? Fish oil seems to be implicated in a higher risk of atrial fibrillation, right? The PCSK9 inhibitors have never been shown to really reduce all-cause mortality, right? And there's a new player there's a new drug on the block now, inclisiran. I hope I'm saying that right. It just got approved about a week or two ago. And really, all they know is that it lowers LDL. The outcome studies are still going, right? So these are the medications we have. And I think the most reliable evidence is with the statins. That does that mean you should use them in every case? Let's discuss that. And who should get a statins? Well, if you take all the LDL trial data, I'm sure most of the clinicians here have seen this before. And if you map out the effects of statins on primary prevention or secondary and high risk, it seems the higher the risk, the more the effect, right? The drugs work better and people are more likely to have an issue, right? This is why I think the AHA and the ACC have transitioned towards a risk approach versus a number approach. Because when you see, if you're dealing with primary prevention, the effects are much less likely, much less profound. And maybe a couple of days at best. In secondary prevention, we're talking about a month or a couple of weeks, right, from continued use. So it seems that these drugs are more effective if we can determine who's high risk. Well, who exactly is high risk, right? We use those two risk calculators. Now, if you look at the 20-year data from WASCOPS that looked at pravastatin, they basically randomized patients to pravastatin for 5 years and then said, take whatever you want afterwards. There was a mortality benefit at 5 years. And that mortality benefit from pravastatin persisted when they did chart reviews at year 10, 15, and 20. Right? So that means that whatever happened, right, these didn't regress, right? They didn't come back, they didn't converge, meaning whatever effect that medication had, it had a sustained effect. Right? It was a preserved effect on all-cause mortality. Again, not by much. Well, we looked at the epidemiologic data. We looked at the medication data. Well, let's look at the gene data, right? When you line up all the genes that we know of that consistently raise and lower cholesterol, and you draw a line, what do you see? A linear relationship between cholesterol and heart disease, right? This is the basis of the cholesterol hypothesis. Now, are there other factors? Certainly, there are other factors. Is this factor interrelated to others? Absolutely. You saw in my 5 patients, something is driving that LDL, right? So basically, the reason why doctors are so aggressive on lowering LDL, right, is because they believe all the evidence points in the same way, right? All the evidence points in the same way. But does that mean I should treat each one of those patients the same that I just saw in my case, right? Should I be treating them all the same? Should we be lowering everybody's LDL, right, with medications? Well, how can we determine what about this special population, what we should do, right? Will those guidelines and will the reasons for those guidelines help my patients? Do we have more specific information about the carb-restricted population? Okay, now we do. Dr. Nick Norwitz, Dave Feldman, Dr. Adrian Sotomoto, and myself and Dr. Dave Ludwig, We put our heads together. 2 years ago, I went to Dave. I said, Dave, I'm seeing these patients with exorbitantly high, LDLs. And I'm doing a dietary intervention and I'm having great effect. Can we put this in the literature? So I took those 5 patients, wrote up a case series with the help of Nick Norwitz and Adrian, who then analyzed Dave's data set. And what do we find? Some key interesting things. Well, first of all, let's start with the case series. In my case series, these are those 5 patients, those first 5 patients I presented to you, right? Their pre-diet cholesterol was all normal. When they went on a low-carb diet, it skyrocketed, right? And what did we do? We told them, look, it seems to be in the literature when somebody's very lean, like in anorexia, and like if somebody's not eating, right, their LDL goes up. We see that medications that lower sugar, like SGLT2 inhibitors, tend to raise cholesterol. So let's add back a small amount of carbohydrates. So each one of these patients added back 50 grams of carbohydrates in the form of starch. Why starch? Because fructose is implicated in increased cholesterol, increased LDL. So we had them add back some starch and we said, you can liberalize carbohydrates otherwise. So some of them had some berries, and what happened? Their LDLs plummeted. In fact, one of those patients had a drop in LDL of 480, which to my knowledge is the second biggest drop in LDL in the medical literature without any medication. I thought that this was profound. So I went to Dave, who's basically done this on himself. I said, Dave, we have to put this in the literature. Cardiologists need to know about this. So we went to Dave Feldman's data set. He had 903 responses in this survey, and we basically isolated 548 that met some inclusion criteria. And what did we find? Before the diet, everybody's cholesterol was basically the same, right? They were basically consistent with the NHANES data set. Their LDLs basically lined up, right? Their HDLs basically lined up, right? In fact, lean mass hyperresponders, those who really see their LDL go up with a low-carb diet, their HDL was slightly higher. Triglycerides in that same population, those who see their LDL go up, right? Their triglycerides are typically lower. But for the most part, it's overlaps with the NHANES data set. And look what happens when they go low carb, right? When they carbohydrate restrict, right, their LDL goes up. In fact, the leaner you are, the more likely it is to go up. The lower your triglycerides are, the more likely it is that your LDL and HDL will go up. And just as LDL goes up, so does HDL, implying that this is not likely the same physiology as FH. This is FH. Wait, before we go there, let's come back. What do we find from this data set, right? The lower the BMI, the more likely it is that the LDL will go up when somebody does a low-carb diet, okay? The more likely it is for it to go up. And the lower the triglycerides and the higher the HDL before they start the diet, the more likely it is to go up, right? This is important. We can predict who will most likely have a high LDL response. We can predict who may even find some favorable LDL responses. The typical person, overweight, obese, coming to you wanting to do a low-carb diet, diabetes, metabolic syndrome, their LDL may not be affected at all, right? It is more likely somebody leaner and has metabolic syndrome, has less factors of metabolic syndrome, like their triglycerides are normal and their HDL is normal, they're more likely to see a higher LDL. But if you do see a higher LDL, what can you do about it? The moderate reintroduction of starch in these 5 patients in this clinic setting improved LDL significantly by up to about 500 points. And in some case, on average, about 200 in this data set. So why is it important that this is different, right? This is different than the FH physiology. This is not exactly what we're seeing when those guidelines say over 190, consider FH and give a statin. We can modify the LDL based on diet, based on carbohydrate reintroduction. This is FH, okay? You can see xanthoma tendinosum. They get these really thick cholesterol-rich Achilles that rupture, right? You can see xanthoma tuberosum, which is cholesterol deposit on the joints, xanthosmas, huge deposits of cholesterol on the eyes, an eruptive xanthoma. This, right, with a family history of early cardiac deaths, this is familial hypercholesterolemia. None of them, I looked in their eyes, had corneal arcus, right, which is cholesterol deposition around the eyes. Right, these are important. And if you look at the Dutch lipid guidelines for FH, it's a point-based system, right? If they have a gene test or their cholesterol is high or they have physical exam findings, right, you use this point-based system. Well, what if we can modify the LDL through diet alone to be out of the FH range? Most of those patients would not be considered FH. And that's exactly what we did. An individualized approach. And why is it important to ask about family history, to do the physical exam, to dig deep? Why is it important to get genetic testing? Because if the gene testing comes back positive, the risk goes up 20-fold. So it's very important. You want to go through a systematic approach to these patients. What was their lipids beforehand? How does their NMR look? Is there any other aggravating factor? Is there a family history of cardiac death or stroke or early cardiac disease? Is there any physical exam findings? What is the genetic test? Have I looked at the end organs, the calcium score, and the imaging test? Right? Why are we doing this? We're trying to understand what it is that patient has. Only one of those patients I presented to you probably fits true FH and really needs risk reduction, right? They all need risk reduction. They all have high, sky high risk factors that can be modified with minor, at least in my belief and what we've seen in the clinic, with minor dietary changes, right? So in summary, all hyperlipidemia is not created equally. Our current guidelines, need a little bit more flexibility for carbohydrate restricted populations. And in my clinic, in an observational setting, a protocol of modest carbohydrate reintroduction significantly improved lipids in an observational setting, right? And it's important to look at the whole picture. On each one of these patients, you want to assess cardiovascular risk. Do a MESA 10-year risk score. Do a AHA ACC 10-year risk score. Get their labs beforehand. Do a physical exam. Get a family history before you tell them lipids don't matter. As I'll tell you, this patient came to my clinic, after an MI, right? Presented to my clinic after an MI. And when you look at these labs and this family history, this could have been predicted. This could have been prevented. I hope that helps, guys. I'm going to go back to the front here. So the end here, bottom line, any questions? If you want to reach me, you can call our office, text our office, reach me on social media at Dr. Tro, visit our site, and then go read our paper on LDL in current developments in nutrition. Share the paper, share it with your cardiologist, let them know. Not all hyperlipidemia is the same. You need a systematic approach. You need to determine risk. You need to look at genetics. You need to look at family history. You need to look at prior diet labs. You need to figure out what's best for that person in front of you. Thank you.
I have just one question for you as a health coach. Can you just give me an idea of a couple of the starches you're talking about?
Yeah, we basically said, look, again, this was a best guesstimate. And we said, what's the ideal carbohydrate? And we looked into the literature, and there's data to say that fructose can increase LDL in the general population. So we gave our best guess and said, try potato, sweet potato, just a modest amount, 50 grams, 75 grams. And again, I just want to say this is experimental. So meaning like there's no study on this. So if you're a health coach working in a team, a medical team, right, you want somebody to be looking at that other side of things, right? Like what is the risk of this person? Because, you know, somebody can have two concomitant problems. You know, I showed a patient who came in with a high LDL that was really drastically different. How would you differentiate those people, right? So it's tough to do without a very thorough evaluation, right? Not, you know, most of the LDLs we see that go up because of the diet probably can be modified, but you may have that one person who's 40 years old and has a family history of, you know, 10 people who've died at a young age whose LDL is modestly increased. And those represent an opportunity where we can actually have a great effect. So again, the starch was potato, sweet potato, you know, if you want some berries before exercise, and, you know, and it seemed to work. You know, we have had some patients where that didn't seem to work and the risk is through the roof, right? So just, that's just one thing to say. Yeah, again, potato, sweet potato, to answer your question. And again, this is experimental. We didn't run a clinical trial on this. So, you know, bottom line is, I think, you know, not all LDL raises matter, right? And not all LDL raises are FH, and not all LDL raises are need a medication, but some may benefit. And who are those who are more likely to benefit? I think that's the point of this talk. Does that answer your question?
Yeah, it did. Thank you very much.
Hi, Tro. This is David Diamond. So someone on low-carb diet would have low triglycerides, high HDL, perhaps low blood pressure, low blood sugar, and high LDL. So are you aware of any study that has shown that isolated high LDL with low triglycerides, high HDL, and the other factors, that those people actually have more coronary events compared to someone who might have the high triglycerides, low HDL?
The only data that I've seen, Dave, is, you know, early population-based data. You know, somebody like Deidre Tobias just like went through the Women's Health Study data set and showed that, but here's the problem, right? Who above an LDL 200 is, you know, FH, right? Or true FH that may have a genetic issue that may predispose them, has a family history, and who is, you know, modifiable otherwise through diet. I don't think they're the same. So when you look at the population-based data, you know, two LDLs tell a different story, right? I just showed in this case series somebody with a lower presenting LDL with likely sky high risk compared to somebody who had a sky high LDL and a low risk, right? So, you know, the first patient in that case series dropped his LDL by 500. And I believe his risk was lower than that case, you know, the case 6. So I'm not sure that LDL tells the whole story. And you've talked about that. Maybe there's clotting factors, maybe there's other issues that ride along with this issue. But I haven't seen any, you know, the only other data I've seen is that population-based data where, you know, it looks like all-cause mortality is lowest at around 120 to 160 for LDL. And lower than that tends to go up, higher than that tends to go up. That's the best data I've seen. And what are your thoughts?
Well, respectfully, and I'll be getting to my thoughts when I give my presentation, but I'm just a guy, I'm just a scientist, and I base all my opinions on published data, not on opinions. And I'm just looking for a study that shows that if you have high LDL and everything else is good, blood pressure is good, blood sugar is good, low triglycerides is all good, is there any published evidence that high LDL alone, even if the LDL is 500, is there any published evidence that those people have more heart attacks?
Yeah, so the best data I've seen points otherwise. Like as the effect is still there, right? I pointed that all-cause mortality with LDL being kind of like a U-shaped curve. right? The best data I've seen is as you peel back metabolic syndrome, risk goes down, right? As you peel back metabolic syndrome, risk goes down. I haven't seen any evidence that risk gets eliminated. You know, it becomes almost inconsequential or very, very low consequence, but of some minor consequences, the way I would interpret the data I've seen. Okay. So absolutely, to your point, if you peel away metabolic syndrome, which is a much more important risk factor, right, than if you look at the hazard ratio for LDL, you know, metabolic syndrome is like a 3 to 5, whereas LDL is like a 1 or 1.5 or somewhere around there. So, right. So yeah, I mean, does that answer your question? I agree with the sentiment, but I don't think it goes away.
All right, thank you. I'll be interested in your thoughts on my talk. I don't know if you'll be available to see it. Thank you.
But you know what, Dave,
I also want to commend you. I mean, I think your work is fantastic, and getting people to get in better health, better shape, going low carb. I really want to commend you on being an MD that's aware of the good research on low carb diet.
You know, Dave, can I ask you a quick question, because you're the expert? And these patients that came to my clinic, you know, who have these concerns, do you think? So I reintroduced carbohydrate. We saw no increase in triglycerides, no decrease really clinically in HDL. What's the, like, should I leave his LDL at 700? Should we bring it down to 180? You know, we did it with an inconsequential amount of carbohydrates. What would be your, are we just treating a number? How would you approach, you know, hedge your bets, the all-cause data, like, is lower at 140? Like, what's your process for that?
You know, many, many years ago, I decided to become a scientist instead of a doctor because I don't have to be faced with those kind of questions. I do the science. I don't advise anyone on their diet. I'm not in a position such as you are, which actually I admire. You're influencing people's health directly. I'm a scientist, and I just study this phenomenon. So I really have no comment as to what people should do to move their numbers around. And I think we're all here just to kind of learn the science, and that's really what my purpose is. So thanks again. I'll talk to you soon.
Got it.
Morning, Tro. So I wanted to ask you a little bit more about the FH screening, how widely you're applying that, and are you seeing any surprises? In other words, are you seeing people who come with, you know, relatively normal levels of LDL, they do the diet, their LDL shoots up, they don't, you know, they have maybe the kind of weak family history, no physical findings, and you screen them and they turn out to have FH?
That's an awesome question. We've probably run, I want to say, 100 plus FH panels, right? 100 plus, I'd say, FH panels, if I had to give a rough estimate. Not one single FH has been positive. Not one. Now, but if you look at the data, it kind of supports that, right? So if you look at all comers of an LDL over 200, and you run the 3-gene panel, which is the data that we best have. Now there's a 7-gene panel. But if you run that, I think at the time, it was like 2% would have an identifiable single gene, which confers a higher risk. They just say it's, you know, polygenetic otherwise, right? But the polygenetic people are much lower risk, right? I don't know if I'm breaking up there. Did you hear me,
Yep.
Dr. Ovadia?
Yep,
Phil?
got that.
Yeah, so not one came back positive, but, you know, I don't think that's, I don't know how to interpret that, but yes, not one.
Thanks, Tro.
Hey, Tro, this is particularly interesting. Oh, thanks. My wife was diagnosed with FH because of high cholesterol, eating a Mediterranean-type diet. She doesn't do low carb. I've randomly tested her, and she's in ketosis. Real quick, okay? She has a calcium score of 0, and she can't name anyone in her family who's died of a heart attack. So I'm wondering why the doctor gave that. Now, with the calcium score of 0, the doctor agreed there's no reason to offer her a statin, even though her cholesterol scores, and she does eat carbs, are in the 350s, so total cholesterol. And that kind of fits your pattern, okay? But I'm curious, am I missing something about the definition of FH, or did he misclassify her with FH?
No, so depends on what criteria you use. Remember, this is all this is all kind of the art of, and there's some science, but it's the art of medicine. Per the ACC AHA guidelines right now, anything over an LDL of 190 is considered FH. And if you look at the risk score that I put in my presentation, it's basically gives you 8 points, which would be likely FH, right? But if we can literally, by those same guidelines, bring the LDL to 189, now all of a sudden, you know, it's not, they don't have the same points in that risk scoring system, and they don't have the same, you know, it's bottom line is, this is the art of medicine. I think there are lipidologists who probably could answer that question better than I could. But if I would imagine if she had true FH, I don't know what the age of your wife is, but, you know, without any identifiable calcium, it would be, and no physical exam findings, no genetic findings, it wouldn't exactly be the classic high risk FH, you know, that we study, that we know about clinically. So to me, I don't want to give a diagnosis to your wife, this is a medical advice, but I'd say something doesn't add up there. Right? Something doesn't make sense. And now the question is she lean? Is she otherwise metabolically healthy? And, you know, I would, you know, what's her metabolic health and weight?
All right. So she's 56 at the test. And then she has very little visceral fat, but she has the, you know, 56. She's got a little bit of excess, but not a lot. She maintains her weight. You know, so around 130.
I'm just curious, what's her, do you mind sharing her height and weight? I'm just curious.
Well, it's somewhat hard for me. Yeah, like 5'6", 132, 133.
So quite lean, basically, by modern standards. You know, quite lean by modern standards. So, and I'm guessing her historic triglycerides have been low and her historic HDL has been high.
Yes.
Yeah, and she's, so, I mean, I would consider a carbohydrate challenge, get her out of ketosis and see what happens to the LDL. But again, this is just playing with numbers. I think, as you pointed out, with the low calcium score and no family history and otherwise good markers, you know, if you plugged her into that ACC-AHA calculator and the MESA score, you know, I'd be interested to see what her risk score would be, but I'd imagine it's very low. Just at that age, 56 and a 0 score, it's probably you know, she's probably in the top 40th percentile. I mean, maybe Dr. Agustin could tell us probably more off top hand, but she's probably in the top 40% for, you know, I think, you know, 60% maybe positive at that age around, you know. Perfect. So in terms of, you know, that CAC. So yeah, it's a tricky one. And this is what we face in the clinic. Like, what do you do? Right? And it's not always clear. And so this thought, you know, I think the systematic approach, what is the MR, what is the genetics, what is the, you know, what is the family history, you know, are there any physical exam findings, are there any other risk factors that may cause an issue? Should we surveil with a stress test? Should we do, you know, look at other areas for plaque deposition, you know, the aorta on ultrasound, the carotids on ultrasound?
Clear.
Should we do an ABI? You know, these are the things that I would think about. Should we do stress testing more frequently? You know, I think these are important questions. And as you point out, it's an individual, so it needs to be an individualized approach. I don't think a cookie cutter approach applies.
Thank you.
Hey, Tro. Bill Cromwell, lipidologist from North Carolina. Good to see you. Excellent approach, very similar to what we've done for 30 years in lipidology, and that is, you know, when I see numbers that are abnormal, why are they abnormal? How long have they been abnormal? what's up with vessels. And that's the basic trend that you're getting at. What I would add is, as an FH guy who has been on the guideline writing committees, it is the persistence over time of LDL, which is the first entry criteria to consider FH. And to your point, having that look back at what have the labs been, I can see where they were, I can see where they are, that is enough to cast great doubt on an FH diagnosis. So thank you for pointing that out. With respect to the impact of persistently high atherogenic lipoproteins over time, the best model we have is that it's cumulative exposure risk over time. The longer the exposure, the more potential impact. Doesn't mean that LDL by itself drives plaque. Does mean that many things can drive plaque, and when plaque has begun, it is the burden of persistently high atherogenic lipoproteins in that setting, which is potentially problematic and needs to be identified. So thank you for comparing and contrasting the idea that we've gone from numbers are bad, make them better, to what's the risk, why is the risk there, integrate over a broader sense of pathophysiology, and put the atherogenic lipoproteins into perspective, both in terms of causality, driving forces, and then ultimately the shared decision-making conversation, what to do about that.
Yeah, look, I think one of the, no, don't leave.
Yeah, I'm back.
I think, so I think one of the most important things is this beyond the body's self-repair mechanisms, right? And so, I think surveillance will become very critical for this population, which we know very little about, right? So, zero score, I become in an older person, calcium score in an older person makes me a little bit more comfortable. But again, I typically edge towards why not surveil, right? A negative stress test is super helpful. Doing an ultrasound of the carotid is super helpful. An ABI is super easy, right? So surveillance is really key. In one of those patients, he had calcium on an aorta for a gallstone, likely due to, who knows what it was due to, but the evidence was there. It just needed to be dug up. The family history was there. It just needed to be dug up, right? It needed time, it needed thought, it needed consideration. We needed to get records. My staff goes and literally spends hours to get all possible records before somebody comes and sees us because of exactly what you said. What information do we already know? What information do we have, right? And are those people exactly the same? And some of these are not clear cuts. I wish everybody's CAC was 0, or we monitor them and they develop a little bit of plaque on their artery. I'm like, look, you can't keep experimenting on yourself, right? You can't keep doing that, right? There's no evidence that it's benefiting you. You had your CIMT was low and now it's high. You didn't have any plaque 2 years ago, now you do. Right? Whatever, something has to change, right? You're not, and particularly if they're changing more aggressively than the typical aging, right, process, right? So if they're changing over baseline, I think that's a critical thing for me.
Exactly.
So I think you're right. This time is an issue, and then aggravating factors. Is there inflammation? Is the CRP? Is do they have metabolic syndrome? The question sometimes I'm faced is people who lose weight and have that appetite suppression from ketosis, right? And they had, exorbitant metabolic syndrome, high weight, and now their LDL came up to 191, right? Well, what do we improve, right? What do we actually, what's the risk benefit here, right? What is that LDL going to do versus reversing metabolic syndrome? And is there a middle ground? Right. Can we get to a middle ground? And, we've had people bring back carbohydrates and then they start gaining weight. And they're like, Doc, look, I know the risks. I tried. I don't want a medication. Or maybe they do. They're like, I want to go back to low carb and give me something to try because I don't want to gain weight. And that appetite suppression is helpful to me. And I get what you're saying, but is there another way to do this? So I think that those discussions and the spending time. So what are your thoughts on yes, it seems that the cholesterol over time is an issue, particularly ApoB, and I know you guys your team is really aggressive on doing these NMRs and ApoB testing. So what are your thoughts? What's your approach?
Very similar to yours. So it's really simple. Do you have disease? If you have disease, we have a conversation. If you don't have disease, that's a different conversation. And this is one place where, you know, in talking with guideline writers, being a part of some of those deliberations, I can tell you we put a heavy emphasis in 2013 and 2019 in making this a disease-based, risk-based conversation. One of the things that I advised ATP for many years ago was this whole risk-enhancing factor opportunity. To not make this a lipid-driven discussion, make this a risk-driven discussion, and include the 39 to 40 different risk-enhancing factors that are out there so that we can have the totality of conversation. So we're totally aligned on that, and that was my advice to the committee. That's how we included that as a point of additional conversation and a shared decision-making conversation. But I think you're absolutely right, and what I do personally, you know, for 30 years in my clinic, the question is, if you have abnormal lipoproteins, what's driving them? What's up with your vessels? If you have disease, that's one conversation. If you don't have disease, that's a different conversation. And whether we should be concerned or not is don't feed the plaque. Don't feed your plaques. If you feed plaques high quantities of atherogenic lipoproteins over time, that's a different conversation than should we worry about everybody who has abnormal levels just because? And the answer is I don't believe we can for a variety of good data that you and others have pointed to. So I think we are trying to be more cogent in doing the right thing for the right people for the right reason.
Yeah, I want to harp on that because of what Dave Diamond said. And some of these things interplay so clearly, right? As that metabolic syndrome comes down, you know, the LDL goes up, and then you're left like, okay, and the weight comes down. You're like, what do I do here? What's a worse, you know, what's the right approach for the future of this person in front of me? You know, as Dr. Diamond said, you know, when you take out metabolic syndrome, right, what are you left with? And it's not, and he's, to his point, it's not much. I don't think it's zero, but I don't think it's much.
Yeah. So I think the bridge between the two schools of thought, it comes down to disease. Are we talking about somebody who has plaque and disease? That's one conversation. If we're talking about somebody who has not demonstrated plaque or disease, that's a different conversation. I think both parties are right. I think you know, there should be skepticism, and we have to understand that nuance. So I can tell you when we developed the NMR lipo profile back in the 90s, and 17 million samples, 600 peer-reviewed papers later, we learned a few things. And we've done deep dives in many of these data sets, in MESA and women's health, et cetera. And we've teased apart some of these interactions with respect to insulin resistance and atherogenic lipoproteins. That's a different conversation for a different day. But it does boil back to the fact that it does matter whom you're talking about, where they are in their disease progressive process. Do they have plaque? Do they have active disease? Totally different conversation than individuals who are at risk but have not demonstrated that. And you can't treat them the same way, nor should you. And I think this is where more nuance needs to be brought into the conversation. And we should not feel bad about telling people, you can have super high LDL, high ApoB, high particle number, and that may not be consequential under all circumstances. And if it is, it's going to take a very long time of exposure for that potentially to drive something. So once we begin to think in terms of cumulative exposure that way and the bifurcation of disease versus no disease, I think some of these controversies begin to simplify a little bit.
Yeah, I agree with you. And I think that that issue of do you have disease, and this is where screening becomes so important. You know, we send people to lifeline screening basically throughout the country. If they're in the office, we're doing a carotid with CIMT, you know, throughout the bulb, up through the up through the carotids, you know, and we're doing, you know, we're sending people for ABI. We're looking for plaque deposition, and if we find a low amount or low for age, right, we're very aggressive on continuing to monitor. Are they progressing versus their peer group? Or are they getting better versus their peer group? And then ultimately, I think you're right. If the presence, and we've seen CAC decrease. Okay, we've seen it. If it's rare, if it's low, and I'm not sure if it's the margin of error or not, but we've surveilled people for 3 and 5 years now, and we've seen several patients have a decreased CAC. It could be that we're not getting the same cuts on that CAT scan, right? It could be that our bodies have some basic element of the healing process, but our amount of surveillance in this population who we have limited data on is very high, right? So I think people need to really, you know, drill that in. And I love your approach, because if that disease is there, I tell people it's like a chronic wound. If you're on a battlefield and you have a small wound, well, maybe your body's going to take care of it, and you will monitor that wound. You'll look at it. You'll make sure that it's getting better. But if the wound looks bad, you got no problem putting a tourniquet, no matter how bad that tourniquet is for the rest of your leg. If you're going to die, right, from that from that stab wound on the battlefield, you're applying a tourniquet. Sorry for the metaphor. But the idea here is you know, when your risk goes up and you have disease, it's a different conversation. You may want to stabilize those plaques. You may want to harden those plaques, where if it's really low or small or low for your age, you could kind of like say, all right, let me just, you know, there's more of a theoretical intellectual wiggle room. Right. But I'm with you, you know. I'm curious, do you have any thoughts on PCSK9 inhibitors decreasing CAC, the Vascepa decreasing plaque progression versus statins making those CACs higher? And I just want to say a quick thank you, if he's there, Dr. Arthur Agustin, for really helping us do what you and I are doing now.
Right. So I don't want to dominate the mic too much, but I'll tell you that mechanistically, EPA does a variety of things that are not tracked through any lipoprotein pathway. You're talking about due to chain length and position of double bonds, it incorporates well into bilayers. It prevents cholesterol crystal formation, decreases lipoprotein oxidation. One of the committed steps of atherosclerosis is macrophage foam cell formation. You get a lot less of that because EPA is inhibiting the oxidation and uptake of that. You decrease plaque rupture, you decrease thrombosis, you do a variety of things that are very complementary. So in the right patient population, EPA, with a number needed to treat, by the way, of 6, for any cardiovascular event over 5 years, is one of the lowest we've ever seen. So it's an example of things we can do other than just smack LDL in the head. Now, smacking LDL in the head is great. You will lower events, but that's not sufficient, and that's not everything. But it's not feeding the plaque. So the more aggressively you lower LDL, it has a benefit, but the benefit is not a mortality benefit, it's an event benefit, and there's more work to be done. So I think there's more commonality. But thanks, we'll talk later, okay? Appreciate it.
Hi, Dr. Tro. I have a really quick question. For the first, your case patients, the first 5, if they decided they didn't want to eat carbs, do you do an intervention, or are you kind of okay with their LDL being high because they're a different profile?
This is an excellent question. I didn't catch your name, I'm sorry.
Oh, I'm Judy Cho. Nice to meet you.
Nice to meet you. Can you hear me?
Yes.
Okay, perfect. So I think you need to explain it, you need to give them education, right? So like, I can't tell my patients how to live their lives. I can educate them as best as I possibly can, give them the best evidence, treat them like my family, treat them with respect. I can't force somebody to do something. Right. You know, if I suspect there's, some other aggravating factor, like poor mental health, but which is rare. I very rarely do I see something like that. Maybe I'll refer them out. I'll just say, look, talk to somebody. But the overwhelming majority just want to be treated with respect. They understand. They want to be presented science. They want to be presented data, and they want to be treated with respect and are willing to reevaluate some of their beliefs. Now, look, ultimately, if somebody doesn't want a treatment, I am not going to force them. I will present them all the different options, the risks, the benefits, so I can't imagine a world where we would, force something on somebody, particularly for chronic disease. Usually, if I feel very strongly, I'll end up saying, like, look, if you were my family member, I would say, try this approach. I wouldn't let you go out of here and just say no. I'd talk to you about it. So I think it takes time and rapport and respect, and ultimately the acknowledgement that I don't know everything, right? And that ultimately I have to respect their values. So we have had people who said, I don't, I know it's high and I don't want to do anything about it. And I just say, okay, like, you understand the risks. I explained it to you in detail, and we've not, what else can we do? And this is the discussion we just had about surveillance, right? Like, look, you want to go, you don't want a medication, it's not consistent with your values, but then we have to, then maybe we should surveil. maybe we should consider stress testing. Maybe we should consider imaging, right? And maybe that information will change their opinion. So I think just respect, time, and, you know, I think these are the factors. Does that answer your question?
I think the overarching question is, in these LMHR profiles, do you think it's necessary that they have to lower their LDL? And I know that's not proven in science yet, but do you think it's a concern based on the other guidelines that don't really fit the LMHR profile? Is it a risk that their LDL is high and stays high?
Yeah, look, if you look at the all-cause mortality data, it doesn't go down as it goes up. I mean, some data, you know, I have it here. I was looking at the, you know what, let me just bring it up. Oh, geez. Okay, here it is. Can I share my screen? Can you guys see if I share my screen?
I don't know.
Okay, I'm gonna just bring it up. If it doesn't work, so you guys will just tell me. Okay, so I'm gonna share. If you look at all-cause mortality data, and I hope this is coming up clearly. Does this come up clearly? Yes. So this is LDL. This is one population data set where you look at LDL, and as it relates to mortality, certainly low LDL for the, you know, here's the thing, autoimmune conditions, inflammatory conditions, chronic infections, all of these things lower LDL. It's used up in that process, right? We see it in severe sepsis. So there's chronic malnutrition, you know, these conditions are associated with higher mortality. And if you look at so you certainly may not want it to be low depending on your risk factors. And you certainly, you know, we've seen that play out in some of like the statin data for end-stage renal disease. Like they don't get a benefit, right? They really, like in end-stage renal disease, there's, you know, I think that there's no benefit to statin therapy, if I'm not mistaken. Even some elderly patients, I think there's some data saying they may not benefit. So, but what about up here on this end? You know, do you want it to be 300? I mean, I just don't have evidence for that. And there's another data set I'm going to bring up here that I think kind of also echoes that point. And this is from Norsgaard's data, which was published very recently. It had an N of, you know, 100,000. Where, and I basically so that other study basically showed 120 to 160 is kind of that plateau, low park. Norsgaard data mirrors that, where, you know, their lowest LDL with all-cause mortality is 140. So do I have data to say higher is better? I don't really have that data. I don't. So do I want it to be, you know, low? I mean, I guess like around, particularly around this area, this is general population, right? So this is what we're talking about. If you're going to die from cardiovascular disease, right, then I think you want it low, right? You may want it even lower than this. So I think the best data I have is, you know, Gen Pop seems like 140 is the lowest, and that, you know, 120 to 160, let's say, if all the other risk factors are managed, right? And I don't have any evidence to say, yeah, you should be 700, you know? I just don't have that data. Now, to Dave Diamond's point, if you have somebody with anomaly high LDL and you remove metabolic syndrome, you've probably done more good for them than harm, right? You've probably done more good for them than harm. So does that answer the question?
It does. It does. Thank you.
Yeah. I think we just got to play with, you know, we got to play with the, you're just like, it's a best guess, right? But now here's the flip, right? So if you had cardiovascular disease, right, I think the LDL lowering becomes much more important and paramount to the previous questioner's point. If you have disease, it's a different story.
Hi, Tro, can you hear me okay? I'm in the back of the room, not at the camera mic. Okay, great. We've got about 55 people watching remotely from around the world, so we want to give a shout out and say hi to them. They're joining you remotely as well. So Christine asked you if you could comment a bit more on corneal arcus. Am I saying that correctly?
So corneal arcus is basically plaque deposition in the eye. If you do you'll see it later. Again, if it's like FH, if you're doing adult medicine, which is what I'm doing, if they have lifelong astronomic high LDL, you'll basically be able to see that, or when you send them to the ophthalmologist, they'll be able to see that. And it's basically, a rim of white around the cornea.
Okay. Okay, thank you. Mary would like to know if you could comment about products like Arteriosil or chelation. When CIC is high, do you use things like that? Vitamin K in addition to diet?
Yeah, look, I tell people here's the assumptions, right? So when it comes to vitamin K2 and D3 supplementation or MK7, there's data that shows that it decreases CAC but does that necessarily decrease events? That's an important question, right? Which we don't have the answer to. So yes, you can make the number look better if it's low, and I think it's a reasonable bet to take some vitamin D3 and K2, if you have a nominally elevated CAC and you're looking to do something about it. Now, we don't know what that does to events. And look, I don't think there's there's no supplement company is going to run that trial. So you may never have that data, right? So I think it's reasonable to say, look, this will decrease the CAC. Potentially, it looks like that in the data that we have. I think it's, agreeable to try, but there's no data to say that it would actually decrease events. So it's potentially good, theoretically good, no definite, right? No definite. And I would say it's reasonable to take. I'm favorable for K2 D3 supplementation. I think the other thing to think about there is there are things that increase CAC. So higher exercise intensity is associated with an increased CAC, but improved outcomes. So you can't, and maybe Dr. Arthur Agustin at some point could talk about, these things. And same thing with statin therapy. In high risk or secondary prevention, statin use increases CAC, but in those people, it decreases outcomes and even potentially all-cause mortality, although there's arguable interpretations of that data. So I don't think all calcifications are equal and all approaches to calcification are equal. We have to understand that we're in a little bit of a evidence-free zone. But bottom line, to answer the question, I like vitamin K2 and D3. Use a independent lab to verify them. So Valisure, Consumer Labs, or LabDoor to verify the quality of your supplements, because they could put anything and you wouldn't know. Now, the second question here, okay, which is really important, is what about chelation? And I want to talk about this because it's really, really important. Okay, I believe it was the NIH did a massive study on chelation to just put an end to it in CHF. They're like, you know what? All these quote unquote quacks are doing chelation therapy, and we're gonna put an end to this. We're gonna do a big study, and they basically found like, oh my God, there's a nominal benefit in this big study that they did, and it raised important questions. I have never recommended it in my practice for CHF or CAC. I haven't. I'm not very favorable of it. I'm not necessarily against it, but I will say all the, the quack brigade that was saying that this is quackery, then the NIH did a study and, showed this nominal benefit in patients with diabetes. So the data's out. I haven't recommended it to one patient. And I know there's a follow-on study that's going on. Other than, iron overload, kind of not iron overload, heavy metal, I don't think I've ever used that particularly. So, but I will say just observationally, it's interesting to note how those, the science people really pivoted after that study. They're like, the study was poorly designed. They were all saying, well, look at this study, we'll see what the results show. It'll put an end to the quackery forever. And then oops, it seemed to have a very nominal benefit, but I'm still waiting for that. But I found it funny because, I don't particularly like those authoritarian doctors myself. So But anyway, I hope that answers the question.
Thank you.
Hey, I'm Laura Buchanan. I was wondering if the lean mass hyperresponders were losing weight or changing their body composition that might be increasing their LDL with that, or if you've seen clinically that a weight loss does cause any significant bump in the LDL.
Yeah, I'm going to tell you, so it's on a spectrum. I've seen the patients with diabetes and overweight that come in with a high LDL and they get rid of fructose and it kind of comes down. But as the weight goes further down, like, look, if you look at the fasting data, LDL goes up. The bigger the window, LDL goes up. If you look at anorexia, the LDL goes up. And how do you reverse it? Stop Ramadan fasting, the LDL changes reverse. How do you reverse it in anorexia? You refeed them and you gain weight. So I think there's some mechanistic data that really is supportive of Dave Feldman's model. And so kudos to him for really outlining this and proposing it. And there's even drug data, the SGLT2 inhibitors at lower carbs, raise the LDL. So we reverse engineered we reverse engineered the potential mechanisms here and gave them carbs, and most of them were either lost weight or were lean and doing this for other reasons, right? So yes, I think, but my honest opinion is the more you do a low carb diet and the further you lose weight, the higher the LDL will go. You may have like that, kind of honeymooning phase where you lose a little bit of weight and it gets better. But then if you lose more weight, I'm convinced, the lower you restrict carbs and the lower your weight goes, the higher the LDL.
Very good.
That's just my interpretation of my observational data in my clinic.
Cool. Thank you.
Tro, I'm a big fan. Love your podcast, man. Hey, I have a question. Have you seen athletes, like these high-end athletes, lean mass hyperresponder types, that also they go carnivore and their triglycerides jump up like crazy and their LDL's high?
I've seen LDL go up sky high. The triglycerides going high very rarely. I have seen one case, there's always alcohol as a factor, and there's always, coffee is a factor. And, so I haven't seen that extensively, but I have seen the LDL go up. The triglycerides, it's so fickle. I retest them sometimes, and you get this one aberration, then it's gone. But I have seen, the lean people, low carb, with a high triglyceride, but they had high triglycerides before. They fit the LMHR plus high triglycerides. In one case, who we wanted to publish in this data set, but didn't exactly fit the picture. He had a triglyceride of 3. He came to me with that triglyceride of 600. First, we lowered the triglyceride, right? Then we lowered the LDL. And it took, removing carbs, removing processed carbs and sugar, eliminating alcohol. And then, I think we even eliminated coffee. And then we brought back a modest amount of starch, just a low level amount of starch. And he had completely normalized lipids. Somebody who has FH and familial hypertriglyceridemia. I miss you, man.
Yeah, I miss you, man.
Yeah.
I had my own room last night. That was pretty nice. Hey, so along those lines, I've seen the same thing, adding starches back in, sometimes cutting back and even switching over to Ben's workout, and the numbers normalize.
Yeah, resistance training, you're absolutely right. I think you were on point with that. The resistance training seems to help too. Listen, thank you so much. Thank you to you, and thank you to Pam for everything you do for this community. Thank you for everybody who's helped organize this event. And, thank you to the SMHP for basically bringing us together and helping us grow as a professional organization so we could bring this information out for the next 20 years. So I just wanted to say that. And one last thing, Mary, in the Q&A, I know the TAC trial was benefit. I give it credit. I'm still looking at the data. That was the chelation data. And no, don't listen to the, the science blowhards, but, we still want to look at the data. All right, guys. Thank you so much, Doug.